Hi everyone. My name is Nancee Jaffe. I'm really honored to be with you today, and thank you for joining our final presentation in the Quick Bites Tips for GI Dietitian series. I'm really so proud of the GI nutrition team that we have here at UCLA, and I hope that you were able to attend Janelle and Natalie's wonderful lectures earlier this month. And if not, you can actually find their lectures on our website, and I will give you the website information at the end of the lecture. Our final lecture in this series will focus on demystifying fiber, as well as discussing some specific supplements that GI dietitians like to use to combat diarrhea as well as constipation. And I hope this will be helpful when you're working with your patients. So let's start by doing a deep dive into fiber, because there's a lot of confusion and a lot of misinformation, both among providers and patients, such as all fibers are the same. So this is not a true statement, and you'll understand by the end of my lecture why I say that. So it can be very frustrating for a patient to just go to the grocery store or the pharmacy and try and pick out a fiber supplement, not knowing what they're supposed to be looking for. So I hope that the following discussion will help to give you a better idea of how to instruct your patients on what to purchase, and especially what they can eat for their specific bowel concerns. So any fiber conversation should really start by talking about fiber characteristics. So for instance, we need to be looking at solubility, fermentability, and viscosity when we think about the type of fiber that we want to offer to people. So we're going to get a little bit into the weeds here, but I promise that we will emerge on the other side with some practical clinical tips that you can hopefully use with your patients. So let's start by going into solubility. So this is the one most of us are most familiar with. And the definition of solubility is the ability to dissolve in or hold fluid. So when we think of something as soluble, I like to use the image of a sponge, right? It can absorb water, it gets nice and bulked up. And in the GI tract, this means that it can actually slow down how quickly the stool is transiting through the body. So you can imagine this would be helpful for people who have diarrhea. And oatmeal is a great image that you can use with your patients, because we can all imagine a bowl of dry oats. And when you add water to those dry oats, it plumps up, it gets very bulked up because of its ability to absorb water. And if you try to tip that bowl over and dump the contents out, it's going to move very slowly. So this is a good example of solubility. The exact opposite is true for insoluble. So it's not able to absorb water, and it's going to actually move through the gut a lot quicker. It's almost like a pushing agent, right? It adds weight. And so kale is a great example of this, because we can all imagine how crunchy kale is when we bite into it. And even if you put kale in a soup and you boil it to death, that thick vein still stays pretty crunchy. And that's because of the inability to absorb water. It's also good to note that things that stay crunchy usually tend to be insoluble. So this is a way that you can think about it with your patients. So if you have a patient who is having a lot of diarrhea, instead of just offering them the brat diet, you could also give them these other food options. So you'll notice that a lot of these are fruits and vegetables, because those tend to be taken away from the diet first when patients have diarrhea. They automatically go to simple carbohydrates like rice and potatoes, which is fine, but it would also be good if we could encourage them to keep eating fruits and vegetables. We just want to make sure that we're giving them ones that are very soluble in nature, and that often means that we have to take that outer skin off. So for instance, instead of offering your patient an apple with that tough, insoluble fiber skin, we offer them applesauce. This can also be useful for your patients who have any stricturing, narrowing, or bowel obstruction. So the same types of rules apply. And so this is also a list of foods that you can offer to those patients. Insoluble fiber, of course, is going to be the exact opposite. We're looking for the tougher, crunchier, thicker skins of our fruits and vegetables. You'll notice that there's also tends to be a lot more similarity in terms of the outer to the inner portion. So for instance, with a berry, there's a lot less of an inner center, which tends to be soluble, and there's much more of an outer surface, which is why it tends to be higher in insoluble fiber. You'll also notice that that on this list, there's a lot more vegetables and grains, and that's because vegetables and grains tend to increase fecal weight because they just have a higher amount of insoluble fiber when compared to fruits. So that's something else you can talk with your patients about. The next characteristic is fermentability. We're all familiar with this one. This is when a chemical is broken down by some sort of microorganism and we release gas or heat as a byproduct of this. So the more fermentable that a fiber is, the less likely it is to help with bowel movement. So what that means is if you have a patient who is constipated, offering them a highly fermentable fiber is not a great idea. For even someone who has diarrhea, fermentability can actually be helpful. The problem is it can lead to gas and bloating. So we have to think about the patient we're working with and what their symptoms are. And you might recognize some of the foods that are listed under the highly fermentable foods. These were ones that were talked about by Janelle and Natalie in their lectures when they discussed the high FODMAP diet. But I wanted to also point out that there are definitely fiber supplements that fit in the same vein. So we may have to be careful when recommending some of these fiber supplements for that purpose. And in terms of lower fermentable fibers, you can see the list listed there. We're going to go into deeper information about this in the next couple of slides. But let's finish by talking about the last characteristic of fiber that we want to go into, which is viscosity. So most people mistakenly think that viscosity simply has to do with gelling capabilities, but that's not actually what viscosity is really about. So forming a gel can be part of viscosity, but there's lots of substances that are considered very viscous that are not gel forming. And this is because the real definition of viscosity is resistance to flow. So you may remember back to either grade school or middle school that you were given a science experiment where you had an inclined plane and you were asked to take different types of fluids and substances and send them down this plane, and you had to time how quickly they moved. So you may remember that water, because it's non-viscous, was very fast, whereas something like honey or ketchup took forever to go down, and that's because of its viscous nature. It's going to resist flow. So you can imagine that this is a good thing if someone has diarrhea. It's going to slow down the frequency. It's going to slow down how quickly things move. Whereas this may not be such a good thing for someone who's constipated, although we'll talk about some examples where that may not be the case. So now that we've talked about the different types of characteristics of fiber, let's remind ourselves of a few key truths about stool and bowel regularity. So in order for stool to pass, not only do we have to increase stool output, so we have to encourage movement, but we also have to have a nice bulked up stool, meaning it needs to be soft and pliable. So the two main mechanisms are movement and softness. And what really encourages movement, there has to be fiber present in the stool all the way through the colon. Okay, so this means that we want fermentation to be low. So we already discussed that that's an important characteristic when it comes to constipation, is we want low fermentation. In terms of keeping the stool nice and bulked and soft, what this really has to do with is solubility. So you notice that whether the fiber is viscous or non-viscous really doesn't matter as much in this case. That's more about how quickly it transits the gut. Solubility is the more important part here. But there are soluble, viscous, non-fermentable fibers that can still transit quickly. And that actually has to do with some of the mechanisms that go along with driving laxation. So for instance, particle size plays a big role here. So what we learned is that coarser, grittier particle sizes, so irregular shapes, bigger pieces, actually drives laxation. And this is because it can mechanically irritate the gut. It can stimulate mucus secretion and water secretion, and it also encourages peristalsis in the colon. So if we want to help someone who's constipated, we may want to choose a coarser fiber particle, and that can actually overtake the viscosity issue. So this is why a fiber that's viscous, if you're choosing a coarser particle size, it will still drive movement out of the body. Whereas if you're wanting to help someone who has diarrhea, then choosing a powder fine particle size is going to be a whole lot better. And again, you see the same idea with our water holding capacity, that we really want the stool to resist dehydration because water content of the stool is definitely correlated with how quickly it's going to transit the body. And just to take this a step further, so I want to show you some examples of what I'm describing with the particle size. So again, particle size plays a big role in how quickly it's going to move the stool through the body. And so we want to make sure that we are choosing bigger particle size. And that's not only true because of the laxative effect, but what I hear from doctors and patients is, oh, I don't really like prescribing fiber supplements because my patients always complain that they're bloated or they have increased gas when they take a fiber supplement. And that can be for several reasons. So the bloating and gas can occur either because you chose a fermentable fiber type. So that could be the first problem. And we'll give you a list of all of the different fibers that are fermentable versus the ones that are not. It can also be that it was initiated too quickly. So if you have the patient start at a higher dose of fiber, they're more likely to get bloated and gassy simply because of the change in the gut microbiome. So we want to make sure we initiate slow, but then this particle size issue can also play a role. So think about it this way. The more surface area there is for bacteria, the more likely they are to ferment a fiber and create gas as a byproduct. So when you have a fine powder as your fiber supplement, it's more likely to create gas and bloating for a patient because there's a lot more surface area. Whereas these coarser fiber particles actually work really well to keep the bloating down. And so the pictures that you're seeing on the screen are of psyllium husk, the coarse fiber on one side and the fine fiber on the other. And you're going to hear me talk a lot about psyllium husk throughout the rest of this lecture. And that's because I love psyllium husk. It really is a great fiber supplement, and if you take nothing else away from this lecture, when in doubt, go psyllium husk. It is a really unique fiber because of the fact that it's soluble and viscous and non-fermenting. It can work for all stool types depending on what particle size you choose. So if you go for the coarser, grittier particle size, it will work for your constipated patients, and if you choose the more powdered type, it'll work for diarrhea. And this theory has actually been tested in several research studies where they've actually pitted psyllium husk against stool softeners, laxatives, anti-diarrheals, and they were able to pull the patients back to the middle of the Bristol stool chart each time. And there was actually a large randomized controlled trial where they had 201 patients who were diagnosed with chronic constipation. And the group that took the psyllium husk not only had 50% reduction in straining, but they actually had over 85% reduction in global symptoms, meaning that not only did their bowel movements get better, but they also felt better in terms of other symptoms. And this is because we know that when someone is constipated, they often have bloating, gas, abdominal pain. They might even have nausea, reflux, or a poor appetite. All of these can be correlated with constipation. And if we can resolve the constipation, we may be able to help with some of those other symptoms that they experience. Also, I wanted to point out that the American College of Gastroenterology Chronic Constipation Task Force graded psyllium husk with grade B recommendation. It's actually the only fiber supplement that has any recommendation for chronic constipation patients. And it is the only fiber source that is recommended for our IBS constipation predominant patients. And this is because other forms of fiber can actually increase visceral hypersensitivity, which can make the patient experience more pain and discomfort. And that's the exact opposite of what we're trying to do with our IBS patients. So psyllium husk really is kind of the king or queen of fibers. So let's stop for a minute. I hope that I didn't make you feel like this by talking about all of these different minutiae when it comes to fiber. But I promise now we're going to take all of those terms that we just learned and all of that information and try and turn it into something usable and practical for you. So let's just really quickly review the fiber rules. We always start by thinking about solubility, and in general, soluble is good for diarrhea and insoluble is good for constipation. We then want to lay on top of that fermentability and viscosity, which we know have an inverse relationship with the bowel movement. So if we are trying to encourage laxation, we want to reduce the amount of fermentability and viscosity. Whereas if we are trying to pull back or help people with diarrhea, we might want to increase the viscosity and fermentability. We also then want to think about what types of options are we going to give to our patients? Are we going to give them a fiber supplement, or are we going to give them a food supplement? So hopefully the next couple of images will be really helpful for you. And again, we're going to put this on the website after there'll be a copy of this video on the website. So if you're not able to take a picture now, or if you need a copy, you can always email me. What we tried to do was look at all of the fiber literature, which is very complex and very convoluted, and there's a lot of conflicting information. But what we did is we did our best job coming up with what was soluble, what was viscous, what was fermentable, which fiber supplements fall into these categories, and what bowel habit they might be good for. And I just wanted to point out that you see the soluble, high viscous, low fermentability, there's your psyllium husk, and it's really good for all bowel types. I also want to point out that methyl cellulose and calcium polycarbophil are listed there, but with a question mark. And this is because these are actually, so methyl cellulose is an insoluble fiber that the manufacturers chemically altered to turn into a soluble fiber. And calcium polycarbophil is what we call a synthetic fiber. It doesn't actually come from nature. It's something that's man-made. And there's insufficient data to actually show that it's helpful for either bowel type. So the American College of Gastroenterology, that same task force, actually came out saying that the data is just not sufficient enough to be recommending these two to our patients. And I can say they're not ones that I go to. If I have a patient who is using one of them, I might try to help them maximize how they're using it in order to maybe see if they get some benefit from it. But it's very inconsistent, the results that patients get from these different fiber supplements. So they're not my first choice. And the other thing I like to point out is for our chronic idiopathic constipation patients, or our CIC patients, wheat bran is a really underutilized option. It works really well. It's gritty and coarse, so it's got that particle size we're looking for. As long as the patient doesn't have any gas or bloating outside of the bowel movement, wheat bran is a great option for them. And of course, I'm a dietitian, so we always like to try and talk about food first when we can. And so I wanted to also give you this same chart, but instead of putting in the fiber supplements, let's give you the dietary fiber options that you can offer to your patients instead. And I'm actually going to spend a few minutes at the end of this lecture kind of going over those in a little bit more detail. And I wanted you to also have a slide on appropriate dosing for some of the most common supplements that are used, so that if you are going to work with your patient and they tell you they're taking a teaspoon or a tablespoon, it's not working, you can understand how you might be able to help them titrate up or down on these different supplements to get to the right dose that might work for them. So as much as I would love to say that fiber is the answer to all bowel issues, clearly it's not. And there's definitely some cautionary tales that we need to keep in mind. One is that some medications are actually affected by soluble viscous fibers. So this includes our cholesterol lowering medications, thyroid medications, and fat soluble vitamins. So you want to make sure that if patients are taking something like a psyllium husk, that they separate it by at least 2 hours. The research shows 1 hour is usually enough. I try and recommend 2 hours for patients. I often have them take the fiber supplement at night, and they take their medications earlier in the day, and then there's no issue whatsoever. Also, so this is the second take-home point. If you take home nothing else from this lecture, psyllium husk is king, and never use benefiber with a constipated patient. You're going to have a very unhappy patient coming back to you. And the reason is that when you have a soluble fiber that is highly fermentable, it's going to be low laxation despite the viscosity. And this is in part because if you've ever looked at benefiber, it's a powder. So it's just adding more heft. It's not actually encouraging better water holding capacity. It does not work. So unfortunately, giving this to a constipated patient is going to make them not feel good, whereas it works beautifully for some of our diarrhea and microscopic colitis patients. So think about benefiber for that group, not for your constipated group. Also, we want to really think about hydration. So the research is pretty clear that if someone is well hydrated, giving them more fluid is not going to resolve their constipation. But if someone is not taking in enough fluid, and this is especially true of our elderly population where they've lost some of their ability to sense thirst, they may not be hydrating as much as they need to, getting them up to appropriate levels of hydration sometimes resolves the issue, and then you don't have to go into fiber treatment. So you can use the little calculation that I have listed to figure out what the most appropriate fluid intake is for you or your patient, and then make sure that they're getting that before you start a fiber regimen. Also, as I said before, we want to make sure we're really careful with how we initiate fiber with our patients. So if we do it too fast, our patients are going to get gas and bloating and discomfort. So what I recommend is no more than a teaspoon increased every 2 to 3 days. So if you have them do a teaspoon for 3 days in a row, the patient will get a sense of how the fiber is actually working for them before they move up to the next dose. And that way, we only want them taking as much as they need. Most people are not going to need the maximum dose of these supplements. Also, I don't do more than 5 grams, which is roughly about a tablespoon of these fiber supplements in 1 week. So it roughly is going to take about 2 weeks to get a patient onto the right fiber regimen, but I promise you're going to have a much happier patient on the other side of that because you're not rushing the process. Also, if you have a patient like a CIC patient who is complaining of hard stool, we always need to soften before we move. So remember what we talked about those keys to laxation is you not only need to have good movement, but you need to have good softening. And if you don't soften first and you just force movement, it's going to feel like boulders are moving through the colon for the patient, and they're not going to be very happy with that. Also, there are some types of constipation that fiber is not going to work for. So we have to remember that chronic idiopathic constipation and IBS-C are just 2 of the forms of constipation. There's also dysenergic defecation and slow transit constipation, right? And so I love this quote by Kate Scarlatta that adding fiber for some patients is like adding more cars to a traffic jam. If what we need is the anatomy to be moving better or the mechanism to be working appropriately, adding more fiber is not going to help these patients out. And this is where we need to be thinking about other options such as, pelvic floor physical therapy, squatty potty, or more aggressive laxative treatments. And just to drive this point home, there's actually been studies done where they've shown that for constipated patients who are given a high dietary fiber diet, if it did not work on them, 88% of those patients were found to have slow transit, and 63% of those patients were found to have a defecatory disorder. So this is when it's just, you think it's normal constipation. If fiber is not working, maybe reconsider that and see if there's something else that might be going on. The same was true with supplemental fiber, that 50% of these same chronic idiopathic constipation patients who were put on a supplementary fiber, if they did not respond to it, they were actually found to have slow transit constipation. So it's just getting us to think a little outside of the box. All right, so to finish things up, I wanted to talk about some other aids I like to use for constipation and diarrhea. So these are some foods and supplements I love for constipation. So you may have noticed that oatmeal and chia seeds both fall in the same category as psyllium husk in terms of their solubility, fermentability, and viscosity. So if a patient doesn't want to try our fiber supplement, or they are interested in different diet interventions, starting with oatmeal and chia seeds is a great way to go about it. And if you notice that the patient needs both help with softening and movement, for the oatmeal, I would choose more of a steel cut variety in those cases, because then you're adding in more insoluble fiber. Whereas if they just need to bulk up the stool, you can go for an instant oat, right? So you're getting rid of the insoluble, keeping the soluble, and still that gelling capability. With the chia seeds, it really is more about bulking up the stool. So I'll often have patients add in flax seeds because they are 80% insoluble fiber. And if you do them in their whole form, you're creating that gritty, coarse particle size, and that's going to help with movement as well. In terms of kiwis, this is kind of a newer kid on the block. There's been several studies that show that if patients have 2 kiwis per day for a month, it can actually resolve chronic idiopathic constipation and IBS-C. And there's a couple reasons for this. One is that there's a good dose of both soluble and insoluble fiber, but that's only if the patient eats the skin, which yes, is digestible and edible. It's also because there is a proteolytic enzyme called actinidin found in the kiwi that actually stimulates receptors in the colon to push. So it actually encourages movement. And then the last one for constipation is magnesium, which people are familiar with. You want to make sure that you're choosing a magnesium that is a laxative form, right? We don't want it to be very bioavailable to the body. So it would need to either be an oxide or a citrate. Usually the dose is anywhere between 200 and 800 milligrams. And I like to use powders because it allows for much more ease in terms of dosing. And have the patient take it at night because it also is going to be good for stress and sleep. All right, in terms of diarrhea, you already heard a lot of talk about specific sugars and fats that can lead to diarrhea from Natalie and Janelle's lectures earlier this month. So I'm not going to go into those, but I just want to make sure that we're aware of L-glutamine, which if you did not read the article in Gut in 2018 on post-infectious IBS, I highly recommend it. We've seen that L-glutamine can actually play a role if there's any form of intestinal permeability, whether it was created because of chemotherapy, cancer treatments, resections, increased stress on the body, or et cetera. And what we've learned is if patients take about 15 grams or up to 15 grams of L-glutamine, that it can not only help with stool form, but it can also help with frequency, and it can also help with normalization intestinal permeability. And we're running out of time, so I'm moving faster through this than I wanted to, but in that study, 96% of participants did well with this. So this is especially one I use with my IBS post-infectious versions, and also anyone who's had a history of foodborne illnesses or travel illnesses, things like that. L-glutamine is a great one to consider. So to finish it up, I just wanted to show you a couple of cases and how I would be recommending fiber for them. So for an elderly patient who's complaining of constipation, first, of course, I want to make sure that they're well hydrated. If that's not enough, we need to get the stool soft. And so I recommend psyllium husk, which will also allow them to have some movement. And in her case, I'd probably go for a coarse variety. With our lymphocytic colitis patient, you've got a lot of variety here. I usually start with a wheat dextrin. And if that's not enough to slow down how quickly the stool is transiting, usually it will help with bulking up the stool, but it may not help as much with the frequency. That's when I may move on to a guar gum or possibly even a psyllium husk. With someone who's got run-of-the-mill normal constipation or CIC, this is where wheat bran can be a wonderful one, especially for a patient such as this young gentleman who the stool is easy to pass. He's just not going that often. We can just add in this coarser, grittier particle size, and that really helps. And finally, our IBS patient, again, the only fiber we should be using for our IBS patients is psyllium husk. So I leave you with several takeaway messages, and I hope that this lecture was helpful. And just as a reminder, we are available to see your patients. So I know you've seen this slide several times, so I won't belabor it. And also, in case you're interested in reviewing these slides, or if you missed one of the parts of this series, all the videos will be available as of next week. 2 of them are already up on the website at the link that you see there. And so I hope that this was helpful, and I thank you.